Good morning, everyone. My topic for the presentation is a forgotten syndrome, Goltz. These are my contents. A 27-year-old male patient came to the department with the chief complaint of missing upper front teeth. He had a road traffic accident 1 year back, following which he lost his upper front teeth and was given a temporary partial denture in a local hospital. He had no pre-existing comorbid conditions or drug allergies. On general examination, patient was conscious, well-oriented with time, place and person. He was well-built and nourished. No signs of pallor, icterus, cyanosis, clubbing, pedal edema or generalized lymphadenopathy. No keratinization or pitting on his palms or soles. His vitals were stable and he was afebrile. On extraoral examination, patient's face was symmetrical. Mouth opening showed no deviation. TMJ examination was normal. No preauricular swelling or erythema. No tenderness on palpating the muscles of mastication, and no palpable submental, submandibular or cervical lymph nodes. On intraoral examination, he was missing 1, 2, 6 and 4, 8. Size, shape and texture of the teeth were normal. Mouth opening was normal. Occlusion was stable. Soft tissue examination revealed no abnormal features. An OPG was taken for planning an implant and it revealed an impacted supernumerary teeth in relation to the 1121 region. It was associated with a radiolucent lesion with a well-defined sclerotic border. In the mandible, there was a radio-opaque mass in relation to the 4445 region. Surgical enucleation of the cystic lesion, removal of mesiodens with simultaneous removal of radio-opaque mass in the mandible was planned under general anesthesia. A clavicular incision was placed from 1-2 to 2-3. Mucoperiosteal flap was elevated. Bone was guttered using number 6 round burr. On enucleation, there was evidence of dirty white cheesy material from the cystic lesion. With a suspicion of odontogenic keratosis, an immediate chemical cauterization was done with Carnoy solution. Once hemostasis was achieved, the wound was closed using resorbable suture. In the mandible, a vestibular incision was placed from 4-3 to 4-6 region. The lesion was excised and the wound was closed with resorbable sutures. Histopathology of the cyst revealed that the lumen was lined by thin, corrugated, parakeratinized stratified squamous epithelium. The basal cells showed reversal in polarity and had a characteristic picket fence or tombstone appearance. The fibrous capsule showed inflammatory cells, extravasated RBCs, and the connective tissue wall showed cholesterol clefts with calcification. These are features suggestive of odontogenic keratosis with inflammation. The histopathology of the radio-opaque mass showed compact osteoid tissue with osteocytes present within the lamina. The chest X-ray revealed that he had a bifid right third rib. Since 2 major and 1 minor criteria are seen, the condition is confirmed as Gorlin-Goltz syndrome. The uniqueness of the case is the presence of an osteoma. Osteoma presence associated with the syndrome is a very rare finding. This is the post-op after 1 week, which reveals complete removal of the impacted supernumerary teeth, cyst and osteoma. Review of literature. Goltz syndrome is an autosomal dominant disorder with high degree of penetrance and variable expressivity. It occurs due to mutation in the patched PTCH gene, which is a tumor suppressor gene. The primary triad is odontogenic keratosis, bifid rib, and basal cell carcinoma. It also produces neurological, cutaneous, skeletal, dental, sexual, and ophthalmic manifestations. It is also known as hereditary cutaneo-mandibular polyoncosis, jaw-cyst basal cell nevi bifid rib syndrome. It was first recognized by Jarisch and White in 1894. It was clinically defined as a distinct syndrome in 1963. However, it existed during dynastic Egyptian times in mummies dating 3000 years back. These are the skeletal findings of 2 male, one of 20 to 25 years old and the other of 60 to 65 years old. There is asymmetric occiput due to enlarged sella turcica, multiple odontogenic keratosis, brachymetacarpalism of the 4th finger, and multiple bifid ribs. The clinical features are cutaneous features involve basal cell carcinoma, palmar pitting, dermal cyst and calcinosis, palmar and plantar keratosis. The sexual features are hypogonadism in male and ovarian tumors like fibroma in female. The ophthalmic features are internal strabismus, dystopia canthorum, hypertelorism, and congenital blindness. The neurological features are congenital hydrocephalus, dural and falx cerebri calcification, high frequency of occurrence of medulloblastomas in children, agenesis of corpus callosum, hence appearance of epilepsies and mental retardation. The skeletal features are spina bifida, kyphoscoliosis, frontal and temporoparietal bossing, brachymetacarpalism and bifid ribs. The dental features are multiple odontogenic keratosis, mandibular prognathism, cleft lip or palate. Criteria was given by Evans et al. To diagnose this syndrome. There are major and minor criteria. The major criteria are basal cell carcinoma occurring under the age of 20 years, histologically proven odontogenic keratosis, 3 or more palmar or plantar pits, bilamellar calcification of the falx cerebri, fused or bifid ribs, first degree relatives having the syndrome. The minor criteria are macrocephaly, impacted teeth, congenital malformation, fibrosarcoma of the jaws, ovarian fibromas and medulloblastomas. When 2 major and 1 major or 2 minor criteria are present, the condition is diagnosed as Gorlin-Goltz syndrome. The management requires multidisciplinary approach. Genetic counseling must be given to patient. Exposure to UV light should be decreased because there is a high risk of development of basal cell carcinoma. Constant follow-up should be there to identify any recurrent lesions. Neurological examination must be done for children every 6 months as there is a high risk of development of medulloblastoma. Ophthalmic examination must be conducted once in 6 months. Odontogenic keratosis are often the first sign of Gorlin-Goltz syndrome in 78% of the cases, and they are usually an incidental radiographic finding. This condition requires early diagnosis to prevent clinical progression and complication. So, dentists play a major role in early identification of the syndrome. These are my references. I thank the Surgical Strike team for giving me this opportunity. Thank you.